It moves faster from here. Bugs, drugs, bugs, drugs. Just got one more, the lymphocytes to go through, then it goes real fast. All right, so this was CD4 counts that you need to know. We were just finishing up our HIV discussion. As you saw, even the questions we saw today, HIV is one of the diseases du jour, as I say, meaning they're going to ask you a lot of questions about it. Okay. All right. So anyway, PJP prophylaxis under 200 CD4 count, toxoplasmosis under 100 CD4 count, MAI under 50. Your AIDS defined when your CD4 count drops under 200, and you begin heart therapy when it drops under 100. But anyway, here comes the information coming out of Africa. All these studies were done out of Africa. That's why American physicians were not aware of it till all of a sudden it hit the literature. The way I got wind of it, I remember, because I'm always doing practice questions. So there was a question about how to treat HIV in a pregnant woman. In December, I got it right. This was last year. And then in January, I got it wrong. I'm like, okay, wait a minute. Something has changed in 30 days. All of a sudden, the same answer is now the wrong answer. I said, that means something has changed. And that's when I looked up a ton of information just came in out of Africa. But let me give you the numbers. You'll see why the FDA changed everything overnight. I mean, it's just so compelling. I agree with them. They had to, because everything we were doing, substandard. All right. They came out with information that shows, whoa, look at this. All right. So let's go through it. Circumcision of men was effective, but it does not protect women. It was effective to protect men. So now circumcision had 3 medical indications. Decreases the risk of UTIs, STIs, especially, and then HIV. Okay. For a long time, the number one reason for circumcision was cosmetics. It's not because any medical benefit. But now we've found 3 medical benefits. So now I see that question popping up. All right. The PrEP, pre-exposure prophylaxis. They came up with a duo here that what about before you got exposed to HIV? All right. So in the HIV negative partner. Now remember, in America was not treating HIV negative partners. It was just treat the HIV positive person. They say, well, no, let's treat the HIV negative partner. Could we decrease the transmission to that partner? That way they don't have to separate. Because obviously in a poor country, you're more likely to live if you're together with somebody, keeping a household, rather than you all by yourself somewhere. Okay. And it was remarkable. Tenofovir and emtricitabine, 2 NNRTIs. PrEP was given to men who have sex with men, showed a 44% decrease in transmission and up to 92% if they actually took it every day. Remember, I told you before this, but the only thing we had scoring 92% was Viagra. So that you can see why the FDA, just like they with Viagra, they just stamped it, approved. They said, oh my God, look at this, 92% decrease in transmission rate? Holy cow. PrEP was also highly efficacious in heterosexual couples, not just men who have sex with men, heterosexual couples, the same thing, still protective. And then IV drug abusers, still protective. FemPrep, I mean, they tried it just in women to see if it was going to be efficacious. No, that's because not enough of it came to the vaginal fluid. There's another arm now, I found out is going on where they're doing a vaginal insertion of these medications, and I predict it's probably going to work. Hypergay study, HIV uninfected men who have sex with men who took pill before and after sex showed an efficacy of 86%. But America doesn't want to adopt this one because they know people are going to forget to take one of those pills. But, you know, in Africa, whereas, you know, they're being told, okay, take it here, and what, and they've been watched. Okay, fine. All right, but it wouldn't work here in America. All right, study found that HIV infected partner is treated if the person was treated immediately. And that's why you see it on the ads now. It says, see your doctor. And it's very good ads from what I've seen, encouraging that, hey, you guys can stay together, but make sure your partner is being treated. Okay. That means if you're HIV positive, you don't have to run away from your partner anymore. All right, transmission to HIV negative partner reduced by 96%. Huge, man, huge. And then this is the one that concerns you and me. Post-exposure prophylaxis. That means you get stuck by a needle from a patient. First thing you do, start the doctor or nurse on all 3 drugs. And then test the patient for HIV. This is when it's unknown. Everybody follow that? Start the 3 drugs. Why? Because the 3 drugs decrease transmission in case that patient was HIV positive. Okay. So you start all 3 drugs, do the HIV test. If it comes back negative, usually it's like 3 days. Then you stop all 3 drugs. We're done. Okay. But if the patient was HIV positive, then you continue the medications for 28 days and recheck HIV status. All right. If it's negative, you can stop the drugs. If it's positive, then you obviously continue the drugs. All right. The 3-drug regimen now, the most effective from what I've seen in literature: tenofovir, emtricitabine, 2 NNRTIs, and raltegravir, an integrase inhibitor. This is the best combination. HIV treatment: treat pregnant women throughout the pregnancy. This was the question I told you I missed. Before now, it used to be cut down the HIV treatment to just AZT whenever she's pregnant. Because remember, 3 drugs, we already know it can kill the baby. But in Africa, they said, okay, if you cut down to 1 drug, we were more likely to lose the mother and the baby. So that's why they cut it down to 1 drug. But now here in America, we said, no, continue all 3 drugs. That way we don't lose the mom or the baby. So can the baby die from the drugs? Of course the baby can die. But the baby is more likely to die without the drugs. If you understand, relative risk is always comparative. Okay. With drugs, without the drugs, yeah, okay. Without the drugs is a terrible outcome. All right. And that's because they had a huge enough cohort to do that in Africa. No, here in America, you never get enough people to volunteer for such a study. All right. All right. So anyway, pregnant women, you treat them with all 3 drugs throughout the pregnancy. I've seen that question twice now on UWorld. And then you intensify the treatment again if her viral load is detectable in the 3rd trimester. We add IV azathioprine, another toxic drug. Okay. And then they say, what do we do for the baby? Because the baby's at risk now if mom is positive. They just came up with this. There was no trial for this. And nobody's going to put their baby up for a trial like this. All right. So they just said, okay, for the first 6 weeks of life, IV azathioprine for the babies. That means we keep the baby in the NICU for 6 weeks. Avoid breastfeeding. Why? Because the transmission through breast milk is about 2%, but it's 0 with bottle milk. Next, automatic C-section. Because there's always vaginal bleeding when the baby's coming out. Well, the baby will pick it up then on the way out. But if you do a C-section, less chance of ever picking it up. The problem is AIDS in the first year of life is called wasting syndrome. The baby just withers away to nothing. It's sad if ever you see a case. I mean, because a kid, no matter how much he feeds, his metabolism just lose weight like crazy. Lymph nodes enlarge everywhere. And he just goes downhill quick. 90% death rate in the first year. They don't even see their first birthday. So that's why they had to come up with something. We got to do something to help these babies. And they say, okay, IV azathioprine in the NICU for 6 weeks. Okay. All right, strategy, the SMART trial still going on, right? Showed that continuous therapy had the better outcome than any interruption. So they interrupted in 1 year, they started dying faster. 2 years, 3 years, no matter when they stopped, they kept dying faster. So then they said, okay, fine, forever. And so the trial shows the longer you do therapy, the longer they'll live. So you no longer stop the treatment for any reason. Okay. And then I want to just introduce you to some of the drugs out there. The entry inhibitor, all of them have FU in it. All right. Fusion, it's short for fusion. So whenever you see FU, it blocks fusion. There's another drug saying FU, man. Oh, yeah, that's right. All right. But anyway, that's what I know. That's why I only put 1 on here, but there's like 3 or 4 of them out there. CCR5 receptor antagonists are already being used right now. Moraviroc. I already saw a question on UWorld a couple of years ago. Okay, because this one, again, coming out of Africa, but they said, wait a minute. If I can create a CCR5 mutation, you heard what I said before, right? HIV cannot penetrate the cells. So it makes sense that they started, let's try this one right away. That means when somebody's been exposed, let's say their partner has it, we can give you this, let's try that. And it does work. Stops the virus from penetrating the cells. Okay? Reverse transcriptase inhibitors. All right. There's nucleoside and non-nucleoside. These are the ones that have been out the longest. All right. AZT, been out the longest. All right. They take the place of nucleotides. So is that anti-metabolite or alkylating agent activity? Cynthia. Angie. Anti-metabolites. So what cells in your body can be affected by these drugs, Angie? So slow dividing or rapidly dividing cells? Rapidly dividing. Where's the most damage going to be done? Bone marrow. So you guys already know everything about these drugs, okay? So that way you don't go memorize AZT, A+ anemia. You already knew that, okay? Don't write that stuff down. All right, AZT is the most notorious for causing A+ anemia, but all of them could do it. 3TC, nothing unique. The 4 with D's in it, D for deadly. They all cause cardiac toxicity. So a lot of people do an echocardiogram before you start these drugs. D for deadly, so easy to remember. DDI and DDC cause pancreatitis and painful neuropathy. Does that make them fat or water soluble, Cynthia? That's what I said. How do you know it's fat soluble? No, because it's just another membrane. Remember, liver and muscle was the top, but I told you pancreas is number 3 for fat soluble. Okay, see, it's because that hesitation you got all over your eyes. That's why I had to ask you a follow-up question. All right, show confidence. You don't get a follow-up question. Anyway, so just don't forget, you know, once a day. You can figure it out based on that. All right, so anyway, any questions on that? All right, cool. Integrase inhibitors all have
Tegra. Question, please.
All right, hang on. Let me just finish these drugs. Integrase inhibitors all have Tegra in their name. So easy to remember. The one we're now, the most commonly used right is Raltegravir. Protease inhibitors all end in Navir. There's about 4 or 5 of those too. But Indinavir is the only one with a clue because it causes kidney stones. Does that make it fat or water soluble, Mabel?
Sir.
Indinavir was one I was speaking about, Mabel. There's still something wrong with her sound system, I'm telling you.
Indinavir, okay.
Indinavir causes kidney stones. Is it fat or water soluble?
It's fat soluble.
No, fat soluble doesn't go to the kidney, Mabel. Yeah,
okay.
Remember that pattern that I gave you guys. So anyway, otherwise they're all once a day. So once a day is fat soluble, but this is the only one that's water soluble. Okay. All right. Recommendations, current recommendation. Make sure you get this down packed in your head. 1 integrase inhibitor plus tenofovir and emtricitabine is for treatment of the patient who's got the disease. Everybody follow me? And then tenofovir and emtricitabine by itself is for treatment for the partner of that person. That's not a standard of care. We treat the partners now. Okay, and based on the data I saw from Africa, man, it's very worth it. All right, Mabel, you had a question.
Please, what's the meaning of DDI, DDC, and DT, please, and TC?
Now they'll put those letters out there for you. They usually put it in parentheses, so you don't have to worry about that. But I know like one is the DD Didovu, I can't remember. Didonosinus, I don't remember. But anyway, they'll put the DDI in parentheses, so that's why I don't try to pronounce the names too much. All right, AZT, I know is Zidovudine, and I can't remember the name of the other ones. All right, moving on. PJP prophylaxis, trimethoprim sulfamethoxazole, like I said yesterday. And because they're gonna have to stay in it for the rest of their lives. Remember, they don't come off of this stuff. They're always susceptible for the rest of their lives. You have to give them leucovorin because both of these drugs block folate synthesis. So leucovorin, remember, gets turned into folinic acid, which your cells can use and therefore recover. Otherwise, everybody would have a severe megaloblastonemia once you start them on these drugs. Once again, somebody with HIV, CD400, 200, you start this drug, you got to know they got to stay on it for the rest of their lives. You can never stop it. Pentamidine is the backup drug if they can't tolerate it because of sulfur allergy. Then you give them pentamidine by breathing treatment. That was done twice a week. Josh. Oh yeah, leucovorin is automatically given with methotrexate. Yeah, it's just that anytime you give any drug that blocks folate and you're going to use it long term, we always get leucovorin with it. Yeah. All right. So PJP prophylaxis. Drugs that block dihydrofolate reductase, you should know all three. Methotrexate, we already talked about. And now here comes two antibiotics that we're going to be using quite a bit. Trimethoprim and pyrimethamine, both antibiotics. All right. The sulfa drugs work by blocking PABA, paraminobenzoic acid, which is a precursor for folic acid. And that's how to remember why we don't use these sulfa drugs in pregnant women or in small children. You don't want to be blocking their growth. Now, we went through a bunch of sulfur side effects. Hopefully, you guys have reviewed it. I told you, make sure you know it, because one day it's going to come up on your test questions. Abdullah, you have a question?
Yeah, Dr. Frank, when it came to the post-exposure prophylaxis, you said we're supposed to take it before 72 hours. So is it up till you find the patient with negative results, or you
Right.
continue?
Yeah, 72 hours until the results come back negative, then you stop the drugs.
And it's once every day, right?
But yeah, most of the drugs are once a day. Just take it in the morning.
Thank
Yeah.
you.
All right, sulfamethoxazole is the most commonly used sulfa drug in the world. Because Bactrim, Septra, everywhere. Because it's cheap. Sulfacetamide is used in the eyes to prevent gonorrhea and chlamydia in non-westernized countries. Now, US, UK, they like to use erythromycin, which costs a little bit more, but sulfa drugs are cheap. All right, sulfacetamide. Sulfaperazone, sulfasalazine, you've seen before. We use it to treat ulcerative colitis. And I told you sulfasalazine was first line. And how do you remember that? It's because salazine is metabolized into mesalamine, which is another salicylate. So you actually get two salicylate for the price of one. Otherwise, either one of them can be used. Sulfasalazine, first line drug for ulcerative colitis. Sulfadiazine, you saw us a couple of times. Remember, it used to treat burn patients. If you're treating a burn patient with this drug, do you want that reaction to be endothermic or exothermic? Devia. All right, Paul Lynn.
Endothermic.
Endothermic because it'll suck heat out of the person's skin. Endothermic means you're pulling heat into the reaction. That means you're pulling heat from the patient's body. All right, sulfadiazine does a good job of that. All right. MAI treatment. Remember, now we don't do prophylaxis for it anymore. We worry about it when it's under 50 CD4 count, but we don't do prophylaxis. I told you they found only less than 1% actually benefit. And it's not justified anymore to put 99% of people through drugs and side effects and costs so that one guy gets treatment. Now you just wait until they have symptoms. Okay? All right, clarithromycin and azithromycin, the macrolides, two best treatments. Macrolides, one of the three drugs that blocks translocation. So let's talk about that. Now you heard this in DNA, RNA lectures, so hopefully you still remember what translocation means. All right, that's how macrolides work. They physically get in the way, so now you cannot shift over to another codon. All right, and then clindamycin and lincomycin. Now, lincomycin has been taken off the market because his brother clindamycin was better. So let me talk about them first. Clindamycin blocks translocation. That's the action. You know, that's always the first thing they're going to ask you. Second is what can they cover, Melissa? They cover all gram positives, including Staph aureus. Simple gram negatives. That's like E. coli, Proteus, and all the ones who end in Ella. And then all your anaerobes. And we've talked about anaerobes above the diaphragm. We use clindamycin. Again, that's just what the experts, you can use any of them anywhere you want. But for test taking, that's why I'm just teaching to you. For test taking, that's you don't argue with a test writer. Just whatever they like, I like. All right, so I can get maximum points. But you don't say because you don't have it. This is if you're in your hospital. Oh, we don't have the clindamycin? Here's a Metro. That's it. You use any of them you want. Okay. All right. But clindamycin. Side effect, though, this is the number one cause of pseudomembranous colitis. So I'm going to give you an update on how to manage pseudomembranous colitis because it's so common now in the hospital. Now, any antibiotic can do it, just so you know. In this case, it's tied to Pen-V, which is the simplest penicillin, it still does it. However, clindamycin had the highest rate, 40%. That's very high, which is why people don't use it unless you really need anaerobic coverage. So, pseudomembranous colitis, diarrhea following antibiotic use. This is where I like to just say in a simple way. So that means any antibiotic and you start getting diarrhea, I'm thinking pseudomembranous colitis. What do you see? Remember GI? You see the pseudomembranes. This is this thickened tissue on top of the mucosa. That's why they call it pseudomembranous colitis. You can see the pseudomembranes in the colon when you scope them. So anyway, what do? The best drug is vancomycin. Is oral vancomycin for 5 days. That's how you start. It doesn't work. That means they still have symptoms. Repeat. That means if it's not completely resolved, repeat another 5 days of Vanco. After 5 more days, still got symptoms. Okay, that means that this probably is going to be bad. So what do? Check a CBC. The CBC will at least tell me whether it's going to be really bad or not. If it's less than 15,000 white count, treat him at home. If you got more than 15,000 white count, put him in the hospital. The new C. difficile, folks, has a 35% mortality rate. I was shocked when I read that one. My time, back in the 80s and 90s, it was 0 death rate. Nobody dies from C. difficile. And we used to treat it with simple old metronidazole, which was cheap and generic. All of a sudden, now this thing is mutated. So that's why they always expect you to keep up with what's going on in the literature, because if you use metro, the patient can still die from it now. And then it's called malpractice if you did that. All right, so at home, what do? Now you were doing by mouth, anal vanco, but in the butt. If that still doesn't work, what you should do is also probiotics. Make sure they're taking probiotics, yogurt. Remember, what you're trying to do is reestablish their normal flora. That helps always. While you're doing that, Vanco's still not working, and Vanco's coming from the top and the bottom. Then you can use, there's 2 other drugs, fidaxomicin. Fidaxomicin, I believe that's how you spell it. And ceftaroline have been used. And then if all else fails, fecal transplant. Nobody thought we'd be doing this. Gonna fill you up full of crap. So when somebody says now you're full of crap, they're actually telling you the truth. Yes. Huh? This is pseudomembranous colitis. Yeah. The antibiotic kills off some of your normal flora. C. difficile grows like crazy, and that's what's causing it. But now it can kill. Before it didn't kill anybody. All right. So anyway, fecal transplant, how do we do it? All right. We ask a family member of yours to go poop into a basin, a big tub, and we collect all the poop. Why? Because your family member has the same normal flora as you do. That's why we always go to a family member. All right. Of course, the family member is embarrassed to do it, but they'll do it because it's their family member. That's not the worst of it. I feel sorry for the guy who's upstairs in the micro lab that day, because you have to deliver a pan of poop to him, and then he has to put it in a blender. That means your mask better be working real well, man, because it's gonna stink real badly. All right, you put it in a blender, put some normal saline, mix it. They have to mix it up into a slushy mix. Yeah, it has to look like a slushy. And then they bring it down to you. Now I feel sorry for you, because if you're the one who's gonna do it, it ain't a pretty sight. All right, you take the poop and we put it into a like 50 cc syringe. We do it in 50 cc aliquots. So you put a rectal tube in, squirt, 50, or you can do nasogastric. I know it ain't pretty. A lot of people gag and vomit. What are you gonna do? You got to get the flora in there. Okay. Yes. Now there's a company making pills out of poop. Yeah, so that way you can just swallow the pills, and then it melts inside your intestines, and there's no more flora for you. Why? Because they know that fecal transplant is going to quickly become first-line treatment for this. That works better than the drugs. Yes. After one treatment, I think the efficacy was like 71%. After two, it was like 92%. That's huge. So see, that's called marketing in America. Somebody's taking advantage of that. What they're doing is you can donate your poop and they will test you, for common diseases, make sure you don't have a disease at the time, but they'll collect your poop, pay you $100 and then take your poop and make pills. Because one day that'll become first-line treatment. Think about how many hospitals in America, and then this company will make a fortune selling pills with poop in it to people. Amazing, but true, folks. Only in America. Yes. People are doing their own fecal transplants. How were they doing that? Giving it how? They were just feeding it by mouth? Oh, with a syringe. Okay. You had me scared there for a second. Yeah, right. Yep. Yeah, so she's just saying before even this started, people were doing that at home by using syringes. Elizabeth, you have a question?
Oh, yeah. I just wanted to say that I used to work for a lab that did the fecal transplant, and I was the one
girl, I'm
responsible.
gonna send you a card, okay?
And I was the one
I'm telling
responsible
you,
to do the
I used
slushy.
to feel sorry for the guy. I'm like, they don't pay him enough. I'm telling you, because if I gotta send you up a pan full of poop and you gotta put it in a blender and put some saline in there like you're making a smoothie or something.
Yeah, that
Oh
was
my
me.
God,
I
you know
couldn't
it's
touch
gotta
smoothies
stink
for a
so
while.
bad
though.
up there. I hope they give you a raise after that one, man.
Yeah, they did.
I don't blame you for quitting. Say, let me go back, go to medical school. This is fun. I'm not doing this job anymore. Yeah, I don't blame you there, girl. Hi, Victoria.
Do you have to do it a certain amount of times?
What? Certain amount of times? No,
The transplant, or
usually we
just
do it
once?
twice. We do
Okay.
one, like I said, 72% of the time, symptoms go away real quickly.
Okay,
If
okay.
The people who are still remaining, we do another one. And usually about 92% will clear up after that. Okay. All right. But anyway, that's a complete update on how to treat it. Now, to detect it, now we have PCR that'll detect C. difficile. Remember, before you had to give a stool sample for that too. Now, just PCR will detect it for you. Yeah, at home, again, you could do the anal vanc, or home health can come do it for the person. But all this other stuff, no, they're gonna have to come in the house for that. Yeah. Fidaxomicin can be used at home. Yeah. Ceftaroline, yeah, that's a 5th generation cephalosporin, correct? Yeah, they have to be in the hospital for that. But fidaxomicin can be taken orally at home. Yes. No, it's not only. Be careful about saying only. Yeah, it's just that it's more likely to last longer in people who don't have an appendix, because they don't have an appendix to reestablish a normal flora. The people who still have an appendix seem to get over this much faster. Yeah. So it makes a good case for eating yogurt. I eat a lot of what's that one? Activa. Yeah, my wife started eating. I started eating it too. It tastes pretty good though. But that way you got probiotics. I mean, it's not poop. I mean, every time I talk about it, I get the chills. I'm like, I don't like it, man. Anyway, that's life. So macrolides. Macrolides, you already know how they work. They block translocation. What do they cover though? All gram-positive, including Staph aureus. Remember, action first, what do they cover, and then side effects. All gram-positive, including Staph aureus. Simple gram-negative, same list I just gave you. But no anaerobic coverage, 0. Macrolides are found to be anti-inflammatory. That was an action that nobody knew for a long time, but now we know. All right. Side effects. GI upset. It upsets your GI so much for a diabetic with gastropathy, it wakes up their GI tract. So somebody came with the idea, why don't we make use of the side effect? And it worked. That's how erythromycin became the drug of choice for diabetic gastroparesis. It irritates their stomach so much, all of a sudden peristalsis will start back up. So, irritant to the GI, that's the number one side effect. Yes. No, it's not they don't. This is just another drug you can use. You can use any one you want. Metoclopramide we already discussed. That's a serotonin agonist and a dopamine blocker. Because that one causes a lot of Parkinson's. That's why they wanted another alternative in case, then switch to this or use this first line. It's up to you. Macrolides, remember, increase the incidence of pyloric stenosis, which I explained to you. Because again, it's by irritating your stomach so the peristalsis is even stronger, and that's how you get the hypertrophy. And now you got pyloric stenosis. Well worked out in the literature. I don't know. Let's see. Mitch, can you explain to her? How does erythromycin increase the risk of pyloric stenosis? Josh, can you explain it? So she's not the only one. I've already explained it twice. That's what I'm saying. All right. So here's one more time. Listen carefully, folks. I said it irritates your stomach so badly that peristalsis begins. And so the peristaltic waves are stronger, leading to hypertrophy of pylorus. Now you got pyloric stenosis. This happens obviously only in babies in the first month of life. It doesn't happen later on. But it's the same mechanism by which it helps gastropathy in diabetics. It just irritates the heck out of your stomach. When I was in pediatrics, man, that was the number one complaint moms had about it. He complained about his stomach, doc. It just irritates the stomach, you vomit. So the mothers hated it. And so I stopped using it because they were complaining all the time. Yeah, it increases GI motility by irritating it. And that's how then you can get hypertrophy because the pylorus is contracting harder. Yeah. And all of them can do it, but it's mostly erythromycin. Erythromycin does more than anything. All right, next side effect, dysgeusia. You get a metallic taste in your mouth, but it goes away when you stop the drug. So you tell the patient it's okay. Because I used to use clarithromycin when I got sinus infections. Thank God with the shots, I don't get it anymore. But I always had this metallic taste in my mouth, but it always went away, so it's not a big deal. Next one, it blocks P450. Blocks P450. Next one, cholestatic jaundice. What does cholestasis mean? It means it blocks up the biliary tract. Remember, fat soluble. So on the way out, it just clogs up biliary tract. And now you got all this bilirubin just stacking up. Karis, did you have a question? Simple gram negatives, I said, was E. coli, Proteus, and all the ones who end in Ella, like Salmonella, Shigella, Francisella. We got a bunch of them. That means they're easy to kill. Yeah, things like Pseudomonas, Serratia, no, they're not so easy to kill. And you need 2 antibiotics to even treat them. Yeah, so that's why they give them that title, simple gram negatives. All right, so those are the main side effects of macrolides. All right, from the top, erythromycin causes the most GI upset. Clarithromycin causes the most dysgeusia. And then azithromycin has the longest half-life. Longest half-life is like a day and a half. Does that make it fat or water soluble, Adnan? Fat soluble, large or small molecule, sir? Small, charge or uncharged, man. Uncharged, acid or base. Base, hard or easy time across the membrane. Easy, volume distribution, high or low? High. CNS toxicity risk, high or low? High. Top 2 side effects, sir. Why are you saying nephro? He was rolling. As soon as he became conscious that he was rolling, that could have now drawn a blank. All those answers, as soon as he became conscious, see? As soon as I paused for a second, then all of a sudden he's back on the track. Hepatitis, myositis, same old stuff. You guys already know all the side effects. All right, so anyway, azithromycin because of the half-life so short, is the only drug that has a 3-day regimen for pulmonary infections. 3 days, you're done. But notice that actually lasts for 5-6 days. That's why. 5-day treatment for everything else. That's really about 10 days. But compliance is better. People like it when they don't have to take it for so many days. So a lot of business people, professionals always, hey, doc, can I get that Z-Pack? You know, for whatever infection, you say, can I get that Z-Pack? Because they all talk about it. Yeah, just ask for a Z-Pack. You don't have to take it for 5 days and you're done. Okay. All right. Azithromycin used to have 1-dose treatment for chlamydia, but remember now they like doxy to treat it. And even had 1-dose treatment for gonorrhea and chlamydia, still used in non-westernized countries because it's cheaper. You know, America likes ceftriaxone for gonorrhea because it works better, like 98, 99% coverage. Azithromycin was like 88% coverage. Abdullah, did you have a question? I see your hand is still up.
Yeah, I wanted to ask you, what was the indication for the macrolides again?
Indication for macrolides, I just said all gram positives, including Staph aureus, simple gram negatives, and then all your atypicals. Remember, their first line for atypicals. I forgot to mention that. We talked about it before, but I didn't mention it. All right.
Thank you.
Macrolides, HIV, folks. Look at this. The most common cause of death from 19 to 44. Can you believe that? Think about this now. If you're dying at age 19 because of HIV, when did you pick it up? As a teenager. That means you picked it up as a teenager when teenagers think sex is just a game. And so they have plenty of sex with as many strangers as they can and don't keep count of anything. They pick it up and then boom. All of a sudden, 19 on, they start dying from it. It's a sad but true statement. I remember this, let me just tell you this quick story. First year in medical school, I went to visit my sister. She was out in California. And I said, it was a spring break. So I decided, let me go on spring break and spend a week with her. So we had a good time. We went out to dinner one night with a group of her friends, a bunch of young males in their 20s. And I was so happy to see so many young males, professionals. Some people were already in business, some were, you know, all kinds of companies that started their own businesses even. The problem was all of them were gay at that time, right? The next year when I came back, all of them were dead. All of them were dead. I mean, it's like 8 or 9 guys. You know how strange that feels? You know, you and I having dinner. The next year I hear you're gone. I mean, just 1 year later, all of them wiped out. Not even one left. Scared her so much, she came running back to Chicago. I'm serious. It scared her so much. You know, she said, oh my God, this HIV out here just kills so fast. But she lost all of them. I could not believe it. But anyway, that's what happens. That's because, again, when they're young, they have sex so frivolously, they don't keep track of anything. And you don't know who you picked it up from. And then all of a sudden you start getting sick and now it's too late. Like I said, women have the higher risk. So ladies, take care of yourself. Take care of yourself. All right. There it is, folks. Now on to lymphocytes. Yes, sir. Congenital HIV, remember I told you, it's a wasting syndrome in the first year of life. I mean, the child just deteriorates quickly and dies. Yeah, they have lymph nodes enlarged everywhere. And they're just, I mean, the child cannot keep up with weight. Weight gain at all. No matter how much that child eats, they're still losing weight every day until they just die of heart failure. Heart therapy doesn't work. We use IV azathioprine. That's the only one that they recommend at this point in time. And even that doesn't stop it. Yeah, so the key is prevention. Obviously, we try to prevent mom from getting it so she doesn't transmit it to her baby. Okay, that's why they say now continue all 3 drugs throughout the entire pregnancy. That's your best shot. All right, let me see. Let me find my lymphocytes. Next lecture. Anybody yell out a page for me? 785. Oh, darn, it's not in here. All right, lymphocytes, the guys who control everything, to kind of wrap everything together, wrap it all up. Lymphocytes, the ultimate control, B cells and T cells. Remember again, you have about 98% B cells for every 2% T cells. All right, we're going to go through both of them and how they all develop. All right, so here's a table I've made for you to kind of help you remember this. All right, to develop, see, keywords, tell me where to look. Develop bone marrow for both of them. See, that's why diseases like SCID, Gaucher's, anything that can wipe out your bone marrow, you got no more immune system after that. Because the T's and B's all gone. Radiation, chemo, pyrovirus B19, see? You wipe out my bone marrow, I got no immune system left. Okay? So everybody develops it in the bone marrow. Now, let's do B cells first. B cells, when they first come out of bone marrow, they have CD9 and CD10. So that's how I recognize immature B cells, 9 and 10. T cells, when they come out of bone marrow, all of them have CD3. So CD3 just identifies you as a T cell, but I don't know which T cell you are. But I notice you also have CD4 and 8. Notice I put them both on the same line because they have both. That's how you know they're immature. They have not declared which one they are yet. Because the question I see is which of the following is a marker for an immature T lymphocyte? You just look for anything that says 4 and 8 on the membrane. It means they just came out of bone marrow. Any questions so far? Develop maturation now. Where do they go to mature? In a T cell, they go to thymus. So T for thymus, easy to remember. And there's 2 hormones that help you, thymosin and thymopoietin. Made by the thymus, acts on the thymus. That's autocrine. It doesn't go anywhere. It doesn't even go into the bloodstream. Those 2 hormones show up when the T cells show up, go away when the T cells go away. They don't do anything else. The thymus is humongous, Justin, when you're first born. It goes across the entire X-ray. That's how big it is. But that makes sense because the baby needs to develop an entire immune system as quickly as possible. But by adolescence, the thymus shrinks away. You can't even see it on an X-ray. That's how small it is. So be careful. Thymus is where they go unless they say somebody who's older than puberty. Then they go to lymph nodes because the thymus is shrunk away to nothing. All right, Justin, you got a question? They come out of the bone marrow, CD3, 4, and 8. No. When they get the thymus, they're going to declare which one they want to be. But when they come in, they have the 4 and 8 already on their surface. That's how you recognize when they're immature. Yeah. What did you think was happening? Positive selection means you declare your number, but you have both numbers when you walked in. You're just going to declare which one you're going to be. Are you going to be a 4 or an 8? If you say you're 4, the 8 disappears. If you say you're 8, the 4 disappears. Now you're permanently one or the other. That's positive selection because the numbers are positive. That's how I remember that. But I've seen so many questions. How do you recognize an immature T cell? The answer always has 4 and 8 in it. That's how you know it. It was there before they got to the thymus. All right. So just so you know. Now they go to the lymph node after that. When they get to the lymph node, so let me move this over here. So lymphoid tissue. I'm just going to say lymphoid. When they get to the lymphoid tissue, they take up the paracortical spot. So paracortex is where you find T cells. So anytime they describe paracortical hyperplasia, do you see they're trying to tell you it's a T cell problem? This is how test writers change up the words to see if you actually understand different words. Paracortex is where you find T cells. And then they get to keep their CD3, all of them keep that. But now they have either CD4, so I'm putting them on different lines now, or CD8, but you cannot have both. So that's how you know they're fully differentiated. And then we have a drug that can recognize, let's see, put it in blue, CD3, if I want to wipe out a bunch of T cells. And it's called mironumab. Mironumab. So if there's a disease where you want to wipe away some T cells, give them this monoclonal antibody. Is there a disease Ida knows where too many T cells? Leukemia. Which leukemia is that? Yes, Cesar? Hairy cell, remember 25% T cell. Or lymphoma, Sézary, and what's it? Mycosis fungoides, it's all T cells. So if you want to wipe away a bunch of them, give them mironumab. Okay. So it's non-specific. That's what I'm trying to tell you. Don't memorize one or two diseases. It's any disease where there's too many T cells, mironumab can help you. Okay. All right. Then what about B cells? Okay. B cells, where do they go to mature? There's something called a bursa of fabricus. And they say equivalent. Bursa fabricus is found in birds. So they figure human beings got to have something similar, right? But hopefully you've learned whenever they got to give a long title to something, what's that mean? It means we have no damn idea what the heck's going on. But if you give it a nice long title, people think you know something. Bursa fabricus equivalent. Oh, okay. Is that south of Chicago, east of Michigan? I don't know. I mean, we have no idea where it goes. Nobody has ever proven it yet. Anyway, but now when they differentiate, they go to lymphoid tissue too. But now they take up the germinal centers. So you'll see questions that will say germinal center hyperplasia. There's the clue. They're trying to tell you it's B cells. That means they're trying to tell you it's a bacteria. If you ignore it, now you're picking a virus and don't even know. They gave you a clue for a bacteria. You can't pick that. All right. Same thing with pericortical hyperplasia. It tells you something once you understand the language. And that's why I say line by line, folks, look at the words carefully. What do they mean? They're trying to tell you something. Now, when the B cells differentiate, they graduate up 10 points. So now it's CD19, CD20, and sometimes CD21. And if you want to wipe away a whole bunch of B cells, we got a mAb for that too. It likes to attack CD20, so rituximab. So this is the way I like to organize it. Hopefully you've learned. Organization is key, folks, because I match up the key words. And I find that they're very, 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 very accurate, just like the questions we did this morning. And I said, gee, there's only one answer. It goes with farms. That's a free point where I come from, because that's one of the clues I use to separate different bugs. Okay. And it gets you a lot of points. Okay. All right. Any questions? Let me see who's going to work with me on this one. Sandra, you're going to work with me on this one. You understand? Follow along. Here we go. We're going to do B cells first. B lymphocytes develop in the bone marrow. Here's my arrow. Mature bursa fabricus equivalent, wherever that is, and differentiated germinal centers of lymphoid tissue. So anytime you see germinal centers is B cells, that means bacteria. Don't ignore it. B lymphocyte differentiation, Sandra, goes like this. The macrophage, remember, it's the guy who presents antigens to everybody. So macrophage can present to T cells, like we've talked about many times. Now you learn it can present to B cells as well. So first, the macrophage ingests the antigen. Remember, I told you, you got to know these steps. Macrophage forms a phagosome. That means the lysosome wraps around it. Then the lysosome digests the antigen, Mabel. The macrophage then presents the antigen. The antigen binds to the MHC2 complex. Remember, MHC2 is for strange antigens. MHC1, I, self, is for self antigens. The MHC2 complex has variable and constant regions. You bind the antigen to the variable region of the beta chain. And then IL-1 is produced by which cells, Justin? IL-1 is made only by macrophages. Nobody else is making it. But from IL-2 on, T cells only. Not only, but T cells control everything else. So IL-1 causes fever, non-specific symptoms of illness, and recruits T helper cells. Again, something you've heard before. Causes fever, non-specific symptoms of illness, and recruits T helper cells. IL-1. And we have a drug that can block in. Let me think about it. And it's scaring, that's it. And it's Kinra. There's another one that sounds just like him. So that finally came out with another one that does the same thing. Anyway, they're IL-1 blockers. And you can use them to stop inflammation due to anything. So they don't have any specific reasons, just they use them like in transplants to stop any response. But you can use any illness you want. You just got to know what the drug does. That's why I only talk about it as we go. IL-2 is considered the most potent interleukin there is because he recruits everybody, no exceptions. And that's because IL-2 on is made by a protein called calcineurin. Calcineurin is a protein within the T lymphocyte that makes all the interleukins. Again, IL-2 recruits everybody. We have two drugs that can block calcineurin and therefore block the beginning of an immune response. Cyclosporin and tacrolimus are used in transplants. Cyclosporin and tacrolimus. The difference is tacrolimus has fewer side effects. The other difference is cyclosporin is the most effective. Remember, you always start with the most effective first. Then if they have side effects, then you switch to the other one, which has fewer side effects, but it's not quite as effective. Okay? So the only time you switch to tacrolimus is when they've had side effects to cyclosporin. Side effects of cyclosporin. Anybody remember this one? Side effects of cyclosporin, Cynthia? Yeah, gingival hyperplasia and hirsutism, and then renal failure. Okay? And then tacrolimus just has fewer episodes of those, but it has the same side effects. So we have a drug to block IL-2, and that drug is called daclizumab. Daclizumab. Monoclonal antibody against IL-2, and therefore you stop the T cells from responding. Next one, IL-3. IL-3 causes B cell proliferation. That means numbers. Where once there were 200, now there's 200,000. That's proliferation. What nucleotide should I label if I want to detect proliferation, Mabel?
What do you say, sir?
I said, what nucleotide should I label, Mabel, if I want to detect cellular proliferation?
Cellular proliferation. What is nucleotide?
That's what I said. What nucleotide should I label if I want to detect cellular replication?
Is it T cell?
What?
Is that what you mean? Nucleotide?
A nucleotide. That means A, G, C, U, or T. That's your 5 choices. All right, Mike.
No idea.
It's thymidine, Mabel, thymidine, because T is found only in DNA. You know, you don't find T in RNA, so there's no mistakes there. All right. If you want to isolate RNA, then you label uracil, because uracil is found in RNA, not in DNA.
Oh,
You
I understand.
that, Mabel?
Sir, I know the question, but just the English is the issue. You know, sir.
Girl, you're speaking perfect English. I don't know what you're talking about. Yeah, it's
It's okay. I'm fine.
Oh my God.
Oh,
Girl,
shit. I know this. This is the cheapest thing. Oh, it's okay.
okay, I ain't asking you no more questions, Mabel. Now you're cussing.
No.
over there.
Ask me. You just have to.
No, but Mabel, don't do that. Just answer the question.
Yeah,
Remember, they're not going to change the language on the test for you or anybody else.
No,
I'm use the same language they use.
No, it's not
Okay?
a language. They will write it in a paper. I will see when they write it in a paper. So I will
Right.
see
I
it when
just
they
said
write it.
The word is nucleotide, so you're supposed to know what a nucleotide is. We did a lecture on it.
I didn't hear you. That's the issue.
Oh, okay. The issue is I didn't hear you. Okay.
So
all right,
please,
so
please, that clear Zimab, is it used for what?
is The Ecluzumab is a monoclonal antibody that attacks IL-2. Did you hear that, Mabel?
Yes, sir, I heard it.
Okay. IL-3 is B cell proliferation. Numbers. That means tyrosine kinase. Remember, growth factor. In case they ask you second semester, you can figure it out. IL-4 controls class switching. So B cell differentiation, class switching. Mabel, what's the first antibody a baby can make when they're born?
IgM.
IgM. When does class switching begin?
I think, is it not 2 weeks to 2 months?
No, not 2 months. Gloria will help you. Is it 6 months, Mabel? 6 months. It's class switching. All right, then you can start making IgG or any other antibody. But IL-4 controls all that. IL-5 controls class switching for IgA only. So we got monoclonal antibodies against these guys. IL-4 is called, let me see, Dupixent, Dupilumab. And hang on, IL-5, Miro, hang on, I gotta remember how I file it away. Wait a minute. Oh man. Who's that? Mipo, yes, a Mipo. I forgot how I tied it to number 5. Because there's so many doggone maps, so you gotta find a way to tie them, or else it's hard to remember them. So Mipolizumab. All right, so IL-4, B cell differentiation, class switching. IL-5, class switching for IgA only. And it also recruits eosinophils. Remember, allergies. And then you got monoclonal antibodies against both. IL-6 is responsible for acute phase reactants. Where do acute phase reactants come out of on them? What organ? The liver. So IL-6 goes in there, a whole bunch of proteins show up. If you have too many acute phase reactants and they get deposited into your organs, what disease do you call that, Meha? We call that what, Bailey? Amyloidosis. Amyloidosis. And what's the good stain for amyloidosis? Ida. Apple green birefringence is what it looks like on echo. What's the stain? Congo red. All right, IL-6 is the acute phase reactant. That's why your SED rate starts to rise when you're sick for a long time. IL-8 is one of the 2 strong chemoattractants for neutrophils, along with who else? Josh. Chemoattractant for neutrophils. IL-8 and Mike. Not IL-10. Miguel. Leukotriene B4 are the 2 strongest chemoattractants for neutrophils. All right, that's IL-8. IL-10, a lower number, suppresses cell mediated. IL-12 is a higher number, elevates cell mediated. So you have 3 things that can shut down cell mediated. IL-10 is the principal guy. Second one, TGF beta. TGF beta suppresses cell mediated. And then CTLA4 suppresses cell mediated. So anytime I see those 3 in a question, I already know where they're going. That means you're suppressing cell mediated, so it cannot happen. CTLA4, TGF beta, and IL-10. The 3 that suppress cell mediated. Why would you want to suppress cell mediated? Karina's asking herself. Good question, Karina. It's because it's a humoral response. You don't need cell mediated. That means your body will make that decision. If this is bacteria, then you need to send a message. T cells, we don't need you. That's what IL-10 does. Okay? And the other 2 guys. Yes, sir. Yeah, IL-2 just sends a message to everybody, come on over. And then IL-10 and 12 will decide whether we need the cell mediated or not. Still, even if it's cell mediated, your first line of defense is still neutrophils. Remember, they're non-specific phagocytes. Their job is to go in and eat everything. Don't take any names. Yeah, then your body will decide, is this humoral cell mediated? And then who's going to take over long term? No. IL-10 suppresses cell mediated. That means T cells and macrophages won't show up. Neutrophils will still keep coming into the area. Yeah. If it's a viral attack, 12 will take over and say, we need T cells and macrophages, and then tell the neutrophils they can go home. No, hemoglobin does not stop because my first line of defense is neutrophil. That's humoral. Yeah, their job is to be there to make sure whoever it is, try to destroy them. But the body will then decide, who is this? And then after day 3, remember that? Starting at day 4, T cells and macrophages didn't show up. They'll take over. But your body's hoping by day 3, neutrophils will clean everything out. Then you don't have to worry who it is. T cells talk to B cells via CD40 ligand. We've talked about that many times. B cells display CD19 and 20 and occasionally 21 after they mature. Stages of B cell development, Sandra. Pre-B cell. How do I know you have a pre-B cell on your hands? Because they'll describe mu as an IgM, mu chains visible in the cytoplasm, but nothing on the surface. They want you to be able to identify all 3 stages. Mu chains in the cytoplasm, nothing on the surface equals a pre-B cell. Immature B cell, all of a sudden you see IgM on the surface. This is why they say IgM is the first antibody produced by every baby, because that's every B cell. They can only produce IgM to start. All right. Or they'll say, what's the first antibody secreted by all B cells? It's always IgM. But the IgM that's secreted initially goes on the surface, not in the bloodstream. That's the trick to the question. If you didn't know the difference, you missed that question. The first antibody secreted by all B cells, no matter what, is IgM. Then you class switch to anything else you want. But the one that's secreted on the surface, folks, is different than the one that's secreted into your bloodstream. Because see, students get the 2 mixed up, thinking it's the same antibody, and it's not. The IgM that's on the surface is a monomer. That means one FAB up here, one FC down here. Remember, the antibody is shaped like a Y. One FAB, one FC is the shape of IgM on the surface. The one that gets secreted into the bloodstream, remember, is a pentamer, 5 FABs, 5 FCs. So easy to distinguish them. IgM is the first antibody produced by all B cells. IgM is also the first antibody that every baby can make. Class switching cannot start till 6 months of age. That's M. And then IgD is the next one to come out. So when I see IgM and IgD, that's a mature B cell. Why? Because he finally has his MD. See, that's all you got to tell your mama. I want to be like a mature B cell, mama. That way I can display my MD. So anyway, that's how I know who's the mature B cell. Or they'll ask you which of these B cells can produce antibodies. You need your license to go to work. So once you have your MD, you can now make antibodies, okay? And now we rename you a plasma cell. Remember that. A plasma cell makes the antibody, but it's still a B cell. And if you want to make a bunch of proteins and secrete it outside of yourself, what cell organelle do you need plenty of, Lillian? The ER, well, you got to say rough ER, because ER can be smoother and rough. Yeah, rough ER, right? Because you got to make a bunch of proteins to be secreted, you start at the rough ER. And what's the label to get a protein to go inside the rough ER, Lillian? Miguel knows this one? Edmond. You know the label for a protein to get into the rough ER? Melissa? That's right, you know I'm looking at you. All right, Josh? Not N-acetylation. N-acetylation occurs in the rough ER, but that's not what I was asking. Gloria, it's called a pre-sequence, guides you into the rough ER. What sequence guides you to Golgi, Melissa? No, mannose substrate is added at the Golgi, but it guides you someplace else. Chris, HSP90 is a chaperone to get to the Golgi, but it's not the label to get to the Golgi. All right, Adnan, it's called a pro sequence, guides you to the Golgi. The HSP90 is a chaperone that recognizes as a pro and gets you there. And then every pro sequence gets cleaved off and destroyed, all except for one protein. Which protein is that, Jess? No, not collagen. Okay. And then you should have said that before you answered. All right. whose pro sequence is not destroyed at the Golgi apparatus? Only one. Yeah, insulin. Remember, it's C-peptide. It's the only pro sequence that's not destroyed. Everybody else's is. Where does all the modification for collagen occur, Jess? Since you brought it up. Where does all the modification for collagen occur? What's that looking at? No, in the rough yard. Everything about collagen, because every other protein you say Golgi, but collagen completely modified in the rough yard. All right, like I said, folks, after this week is called sit down and start reviewing these notes and know this stuff well. All right, so anyway, MD means you're now licensed to make antibodies. To stimulate B cells, Sandra, this one I gave you yesterday, endotoxin and pokemitogen stimulates B cells, and then we put in levothyroxine to detect that it's replicating. All right, what's the difference between a uracil and a thymidine, Sandra? What's the difference between a uracil and a thymidine in structure? There was only one difference. All right, Montessor? Meha? Pauline?
I think the thymidine is methylated and the uracil is
Yeah.
not.
One methyl group, that's it. One methyl group. All right, very good. Primary response, here we go, Sandra. You ready? All you gotta do is look at the screen now. Okay, Sandra, read for me. Now everybody follow along. Stop writing, just follow for a second. When you start making IgM, first 6 months of life, when does IgM first show up? What? 3 days. When does it peak? 2 weeks. How long does it last? 2 months. Everybody see that? 2 months. That's it. Now, when a baby is coming out of mom, the mom gives the baby a bunch of IgGs, a copy of every IgG she's ever made throughout her entire life. Is that passive or active immunity, Angeline? Passive immunity, because the baby hasn't gone through anything. Passive immunity is the most protective during what period, Anna? How long? If it was 2 weeks, we start giving shots at 2 weeks. 2 months is what I gave you guys. Passive immunity is protective for 2 months. That's why we start shots at 2 months. Sandra now knows the shot I gave the baby at 2 months. What antibody showed up? IgM, when did it first show up? 3 days, when did it peak? 2 weeks, how long does it last? 2 months, that's why they said bring it back at 4 months for the same shots. Wait a minute. What antibody showed up at 4 months when I gave him shots? IgM, when did it show up? 3 days, when did it peak? 2 weeks, how long before it's gone? 2 months, that's why they say bring the baby back at 6 months for the same shots. Starting to bring about anybody? The whole vaccine record of America coming to right now. Right now, here's where it came from. But every doctor swears it came out of Harriet Lane, it came out of CDC book. Everybody just memorizes the book. Nobody goes back to learn this. Now, the good thing is I've had at least 3 students call me because they got residencies at a conference where somebody just happened to say, we're not sure where vaccine record come from. In the middle audience, nobody in the audience knew where vaccine record came from. And the first student ever called me, he raised his hand. Well, from what I read and understand, man, come on, broke it down. Broke it down. The whole audience was like, how the hell did he know that? And they gave him a pediatric residency right then in that spot. And he called me, he couldn't believe it. I said, what did I tell you? You're gonna know stuff most doctors don't even know. They just know because they memorize out of a book, but they don't know where it came from. Okay? All right. 2 months, 2 months, 2 months. See that? That's why, because your IgM disappears. I need to give you some more. IgM disappears, I give you some more. At 6 months, you're okay. At 6 months, all of a sudden now, you have primary IgG that shows up. Remember, at 6 months, IgG can be made. Cares. At 6 months, when IgG for primary response shows up, when does it arrive? 2 weeks. Notice at the same time, IgM is peaking. When does it peak? 2 months. Notice when IgM is leaving, he then takes over. How long does he last? 1 year. Add 1 year to 6 months. How old is the baby? 18 months. 18-month checkup for the same shots. Look it up. See if I made a mistake somewhere. Basics all the time. Everybody swears it's not about basics. I said, okay, that means you don't even know what it is. Everybody just likes memorizing stuff. I said, no, I like learning from the beginning. That way I don't have to look it up ever again. I can just figure it out for myself anytime I want. Okay? The whole time period is based on the pharmacokinetics of antibodies. See, again, basics. Doctors don't want to go back and reread this basic stuff. They don't realize that's the reason why you got to look up vaccines for every child that comes into your office. Okay? Came from here. I don't know. Acute versus chronic illness. What do you mean? Yeah. Yep. Coming up. So does everybody understand the shot record, first of all? It came from here. And I'll go through the rest of it for you, but I want to show you where it's all coming from. Okay? All right, back to Sandra. Sandra, when IgM shows up, when does it first show up? 3 days. What's my body doing for me for 3 days? Leaving me naked with no immune system? Eh? Is this like one of those gowns at the hospital where your butt's hanging out and everybody can see it and you forgot to tie it up? Everybody does that at the hospital. You're walking down the hallway, they forgot. Oh, you forgot your butt's hanging out. Everybody's just looking at your butt. Who's protecting for the first 3 days, Sandra? Because otherwise, there's a gap here, man. Any idea? Let's go to Reed. Maybe she knows. No, not breast milk. Let's ask Karina. Isn't it just what? What innate immunity are we talking about? Give me the cells. What's protecting you? No, not because of the cells. Angie, who's protecting you? Is the IgG across placenta? No. Because IgG from placenta is going to be gone in a little while. But every time you have a response, it's still the same 3 days. I'm asking you, who's protecting me for the first 3 days then? Let's try Melissa first. What's that? It's the neutrophils. Why do you think they pick at day 3? What's the innate stuff mean? Innate is not, I know, but you, oh yeah. You got to say the word so I know you'll find the answer. Because you got to, oh, you must find out. So I want you to go to the answer that says neutrophils. There it is. That way, because innate means a whole lot of stuff. So neutrophils peak at day 3 for that reason, folks. Their job is to clean everything up. But if they have not cleaned up by day 3, here comes IgM. Why do you think IgM is the pentamer, 5 arms, 5 FAB, 5 FC, to clean up everything? Because neutrophils by themselves couldn't do it. Then you want the guy with the most arms to show up. See? Yes, Angela. No, when he's born, he can make IgM. Before that, he only has IgG that mom gave him. The baby has not been confronted with any antigen, so he doesn't have to mount a response. Yeah. Yeah, first 2 months. Yeah, and then after that, IgG is still around. They've detected all the way out to 18 months, but it's way below protection. That's what the question says, the protective levels. And students think just because they detected it. I said, no, if it was protected out to 18 months, we'd start shots at 18 months then. If it was detectable, if it was protected out to 6 months, we'd start shots at 6 months. Wouldn't make any sense. We're giving billions of dollars worth of shots if you already have protection. It's because protection with passive immunity is reliable for the first 2 months. After that, you can't trust it. It means the levels start falling below the protection level. Okay? All right. So in the first 3 days, folks, your neutrophils are supposed to protect you. Then IgM will show up. Sandra, I got another one for you. One more. Ready? I got to try to figure this one out. So if you have an infection, okay, is the infection going to be resolved when the IgM arrives, or when the IgM peaks, or when the IgM is going away? Which one do you think? Let me ask Lawrence. When do you think? When IgM is going away. All right, let me ask Montessori, when do you think? When IgM is going away. Let me ask Summit, what do you think? When it's going away. Jess, what do you think? When IgM is peaking. All right, Stephen, what do you think? When it peaks. Bailey, what do you think? When they peak. Think about this, folks. When IgM is first showing up, and when IgM is peaking, when it peaks is when it's going to be way above protection levels. That's when you clean up everything. When it's going away, now you're falling below protection levels again. That can't be when you're finally going to get better. That means, Sandra, one more question for you. That means if you have an infection, how long is it take for you to get over it? 2 weeks. Anybody want to know where the 2 week checkup came from in medicine? How come every doctor sees you back in 2 weeks? Because then you should be over whatever the hell it is. You got a sprained ankle, come back in 2 weeks. No matter what the illness is, come back in 2 weeks. Doesn't matter what it is. Your body always gets it all done within 2 weeks. You should be better. That means no matter what infection they ask me about, you should be better in 2 weeks. Look at when we talked about lymph nodes, lymphadenopathy. Remember, I said, follow them for 2 weeks, see them back in 2 weeks, because they should be better in 2 weeks. If they're not better, fine, we'll biopsy. But if they're better, they're fine. Leave them alone. 2 weeks is throughout the literature, but nobody ever seems to see it. Okay, but that, again, I told you cannot see what you don't understand. It's been there the whole time, but you didn't see it. All right. That means if I have too many antibodies, those antibodies, Karina, are now free to attack something else, are they not? You understand what I'm saying? Then you understand why every autoimmune disease starts 2 weeks after the infection. Check it out. See, did I make a mistake somewhere? Why is post-strep 2 weeks after the sore throat? Why is rheumatic fever 2 weeks after that rash? Why is it always 2 weeks? There it is right there. Every autoimmune disease starts 2 weeks after. Guillain-Barré, whatever they want to ask me about, is the same pattern for all of them. Once you understand it here at the most basic level. Mabel, you have a question?
Yes, I have a question, sir. I have two questions.
Go ahead.
You said
Mabel.
that the IgM, it peaks or it lasts for 2 months. So so does it mean that you will tell them to come back? They will come back for the next 2 months for you to give them another vaccine, then another 2 months, another vaccine until 6 months, right?
That's correct. That's exactly what we do.
Okay, another question I have is you said that in IgG it lasts for 1 year. So you now say 1 year plus the 6 months of IgM will give us 18 months. So what does 18 months stand for?
That's when we give them another shot, the same shots again. We give it again at 18 months.
Thank you, sir. God bless you.
I'm telling you, folks, basic stuff. Because every doctor sees every illness back in 2 weeks. Otitis, 2 weeks. Rash, 2 weeks. Appendicitis, see him back in 2 weeks. It's always every 2 weeks. But none of them actually understand why we see him back in 2 weeks. It's just, oh, we always do that. I told you that's the answers I got. Oh, well, we always do that. That's what's amazing to me throughout medicine. Most doctors have never understood why we do anything that we do as physicians. They just know the protocol says to do this, but they don't even know where that protocol got that information from. And so that's why you get sick of following protocols. If you understood it, you could actually say, oh yeah, that would be correct, or that would not be correct. Okay, but you got to understand normal first. Then it's easy to spot abnormal. So, primary response. Any questions on that? All right, so now you understand autoimmune diseases 2 weeks after illness, always. Okay, now you know why every illness should get better within 2 weeks. Everybody understand that? And now you understand why we give shots every 2 months when the child is first born, and then from 6 months, the next one's at 18 months. Because now they can make IgG. And Rachel, you first. Hepatitis B is a whole new vaccine. Don't you see? It's not even on here. I'll tell you about that shortly. Yeah.
What is there any medical logic behind like the delayed vaccine schedule, or is that more just for like parents who are after?
Delayed. So she's asking about delayed vaccine record. Is this for, you talking about for premature babies?
Oh, just like some parents that are like very affected stuff, like it might be more comfortable for them to be on a different schedule.
No, not at all. That's them just doing that. Yeah. So she's asking if you got a parent who likes to delay vaccines for a child, there's no medical evidence behind it. There's no reason whatsoever. Even in premature babies, they now say just follow the record. You don't have to adjust at all for premature babies. They can respond. There's no way a mother can convince, well, should never be able to convince a physician, oh yeah, they're putting it off for a while. That should help. No, it doesn't. It leaves your child at risk even longer. Remember, what we're trying to do is protect the child, not wait till they've seen all these infections. Now a bunch of them will die because that's normal. If nothing else, 1 to 3% are going to die. Even from a simple virus, 1 to 3% will die. Okay. The key is to protect them so that nobody gets it, or as few people as possible get it. That means 1 to 3% of such a tiny number is negligible now. Okay. That's what we call herd immunity. Herd immunity starts at 60%, from what I understand. That means if 60% population has gotten their vaccine, you're protected. Notice now they're removing all these mandates for vaccine, right? Because I think it was 82% last time I heard. 82% of the population, American population, has gotten their vaccine now. So we got way more than herd immunity. That's why they can say, oh yeah, okay, fine. That means the chance of running into somebody who's not protected and who's carrying COVID in front of you is pretty slim now. That's why they're ending all this stuff. But that's the rules. That's what you're supposed to do. It's not about politics. They made COVID so political, it drove me nuts. I said, when the hell did this start? I thought we were doing this stuff to protect people. And because they messed it up, look at what happened. America, the richest country in the world, lost more people than all the poor countries. They thought, oh, Africa's going to lose a whole lot. That's what I heard. And I was so afraid for my people back in Nigeria. I said, oh my God. I'm thinking, okay, a lot of them are going to die. But I said, well, from what I understand, it still should be about 1 to 3%. Well, because America got it all wrong, it sacrificed its own people. Well, the other countries did follow their own protocols. And how come they hardly lost anybody? It's ridiculous. That's what happens when you don't do what you're supposed to do and you start going with emotional and all that stuff. People are going to die. Remember, people used to die from these diseases. That's what we started vaccines for. We didn't start vaccines just because, oh, it sounds like a good thing to do. No, it's because they used to kill a lot of people. That's the part that people forgot. Okay, that's the part that people forgot. Just like even COVID. Why were we vaccinating everybody? Because people are trying to die. That's why you vaccinate everybody. Not because of the political crap that was started with Trump and his people. It was ridiculous to me. Anyway, so let me just go through this and I'll get your questions, people online. So vaccine schedule. Now, let me give you a big picture approach to vaccines. Listen carefully. We vaccinate those who are susceptible when they're susceptible. So that means all you do is learn when people are susceptible to these infections, then you understand why we give them shots during that time period. The timing is based on the pharmacokinetics of the vaccine itself. I mean, no, sorry, of IgM and IgG, which is why I showed you that first. But now let me show you what are you susceptible to in the first 10 years of life. That's why we give you vaccines, okay? But then we don't give it to older people. Why? Because they're not susceptible to it. You don't vaccinate people who are not susceptible. All right, so from the beginning, diphtheria. Who gets it? 2 months to 6 years of age. After 6 years of age, we use little d. Why do we use little d? As a carrier, if you guys remember that discussion. A carrier just used to amplify the other vaccines. The last time I reviewed some stuff, they say now there's 7 other vaccines attached to that little d. That means now the child only needs 1 shot, but he got 8 vaccines. Okay. All right, anyway, that's diphtheria. Pertussis, 2 months out to age 5. That's why we don't give it anymore after age 6. Tetanus, you get it from dirt. You can't outgrow dirt. And that's why you get it for the rest of your life. See, rather than just memorize it every 10 years, but you don't realize why does it go on forever? Because you can't outgrow dirt. Because you're going to face dirt no matter how old you are. Okay, that's tetanus. Polio, remember we use only the killed polio now. From 2 months out to age 10. 2 months out to age 10. And then not again unless you go into a poor country where it's endemic. Because I remember when I first started going back to Nigeria in 1994, I had to get another polio shot. Because I'm going back into a poor country where polio is endemic. And that's the way it should be. Otherwise, I would never have to need it. All right, that's polio. Hib, 2 months out to age 5. Strep pneumonia, 2 months out to age 10. Yeah, there's a page where all these vaccines are put there for you. I'm just giving you the timeline so you hear the numbers. But if you look at, what's the page on there? 790, you see all the vaccines. Okay? So that means if you take what I'm telling you right now and look at the timeline for all the vaccines, all of a sudden they will make sense to you. Because we don't give the vaccine unless they're in essence of the population I'm giving you right now. All right, strep pneumonia, 2 months to 10 years, and then not again till what is it, 65. Notice why we give another shot at age 65. Okay, you only vaccinate people who are going to get the infection. And that's because when you vaccinate people, what percentage of those people are going to react to the vaccine on them? 1 to 3%. What percentage of people are going to die from those vaccines on them? 1 to 3%. Do you understand my point here? But if you look at pertussis, the old numbers for pertussis used to have a 40% death rate. Now 1 to 3% doesn't sound so bad. See that? That's how the decisions were made. You know what? That's killing too many kids. Let's vaccinate. Yeah, we're going to lose 1 to 3%. And you're sad when everybody's child dies, but you're saving millions of other kids. Okay? But if you forget that and one emotional mother scares you and now you don't want to vaccinate any child, we'll go back to 40% of children will start dying again. Okay? All right. So let me just show you the ones we just did. Remember at 2 months, IgM shows up, gone in 2 months. Do it again at 4 months. IgM shows up, gone in 2 months. Do it again here. But now IgG will show up. That's why you got all the way up to 18 months before you have to give it to him again. See that? Easy to run through the whole vaccine record without guessing. All right, Victoria, you were first with your question.
Yeah, so this goes back a little bit. But so you said since IgG shows up at 2 weeks, that's why we get like post-strep glomerulonephritis at 2 weeks.
Correct.
Why then do we have IgA nephropathy before 7 days, like before the 2 week mark?
Yeah, but if you look up IgA nephropathy, it's not autoimmune. It's immune complex deposition.
Oh, I see.
Yeah, that means as it was going through the kidney, it got trapped in there. That's not the same as
okay, I see.
autoimmune. Yeah, autoimmune is deliberate attack. It's actually attacking. Well, you can't attack till you have an excess of antibody. Yeah. All right. Abdullah Khan, you were next.
Yeah, I was saying about the COVID thing. Isn't it because we had so many comorbidities in the country?
What about it? Is that why so many people died?
Yeah.
Nope. Ask Mr. Trump. I got nothing else to say.
I agree with that, actually.
Oh my God. I'm telling you, every day that man got on TV, I got more and more angry. I got to the point where I couldn't even watch it anymore. I could not.
You were joking about it. Oh,
Thank you, Miss Mabel. I'm telling you, I could not watch it anymore because
Bossa,
I could see that people's lives were being sacrificed. I mean, I went out and got the vaccine. I remember me and another doctor, we put on a little Zoom meeting for people in this area to talk about the vaccine because people were getting so suspicious of it, nobody was getting vaccinated. And so that's why they wanted at least 2 local physicians. Hey, talk to people and tell them this is safe stuff, or else we're going to have a big death rate around here. Luckily, they listened. I don't know because of me or they got, but most people around here got vaccinated. U of I did a good job. Said, no, you're not coming here unless you're vaccinated. That's the majority of this town is U of I students, almost 50,000. So they did a real good job. And U of I never had an outbreak. See what happens when you do the right thing? So the way Trump did it, made it all political. It was a bunch of crap. I even fault the people around him. The only person I gave credit for was Dr. Fauci. He took on Trump. He said, no, that's the wrong thing. Every week the man was getting attacked, but he said, no, he stood firm. That's not the right thing to do. What about that other doctor that sat next to him and said nothing? Pissed me off. What's her name, Dr. Burke or something like that? And then after she left the White House, oh, now she starts talking. Now you pretend like you know everything about vaccines. How come you didn't educate this man? But he had them all scared. They wouldn't even talk. I remember when he was saying, pour bleach down, maybe drink some bleach. And all she did was like, look around like that. I said, you're supposed to say something. You're the doctor. And you're going to let this man say it's okay to drink bleach? Because remember, a bunch of people drank bleach because of him. Man, don't get me started now. Don't get me started. I'm telling you, I was mad for 2 damn years watching this thing happen. And as I'm watching the numbers, Americans are dying. You know, and everybody who believed Trump, they were just dropping like flies. And then every time I watch the news for the update, all the people in the ICUs are almost full. And then they tell you 99% never got vaccinated. And I'm like, how come these people don't understand the vaccine is working when 99% of people in all the ICUs in the damn country are unvaccinated people? You still don't get it? How much more proof do you need? Oh man, it was ridiculous. But I said, well, nothing that you can do about it because they're adults. If they want to die, they can die. Okay, and that's what happened to a lot of them. I remember this one black man who used to follow Trump. He was at his rally, and anybody know who I'm talking about? Okay, what was his name? Anyway, because he was famous for backing Trump. But he followed Trump. He goes, oh yeah, I don't need vaccine. The man dropped dead the very next week. So you still believe you don't need vaccines? Keep going, because all his followers just dropping like flies. And yet they're still following this guy. That's it, Herman Cain. Oh man, big supporter. Dropped the very next week. Talk about, oh no, I'm following Trump. I don't need no vaccine. Yeah, how come Trump got vaccinated? He got vaccinated, but he's telling you don't need a vaccine. And you're dumb enough to follow that. Huh? Yeah, it was no big deal. I didn't even know he was on ECMO. That's just the kind of person he is. He's willing to sacrifice the lives of so many innocent people just to live this lie of his. It's crazy. But I'm telling you, the physicians around him pissed me off. Remember, even his doctor who used to come out and just make it look like, oh yeah, Trump is okay. Like, who the hell are you talking about? Trump is not okay. What's that? Yeah, but he just outright lied. So he should just said, I'm not allowed to give out any information. Then fine, don't give it out. But don't come out here and start lying to everybody. I said, there ain't no way that man is okay. And now I'm hearing he was on ECMO. Hey, my goodness, man. Oh my God, man. And then when the death rate was calculated, it was 2.2. Exactly what I told everybody. It's going to be back to 1 to 3% because that's what science says. But all of a sudden we abandoned science and everybody started getting emotional. And people started sacrificing their kids. Oh no, I don't want my children vaccinated. Okay, fine. Watch the kids drop dead now. And that's why like California, that kid ain't going to school unless he's vaccinated. And I totally support it. All right. If you want your children to die, then keep them at home. Let them die with you. Okay. But don't bring them to school so they infect my child and they die with them. No, I don't agree with that. Yeah. I was so happy. Puerto Rico did the same thing. When I went to visit Puerto Rico 2 years ago, you had to show that you were vaccinated, full record, before they would let you into any restaurant you went to. I said, that made me feel so much better. Every time I walk in, at least I know everybody there's vaccinated. Man, because that was one of the things I said, why don't they just make it mandatory? If you don't show your card, you're not coming in. If you want to die, die at home, but don't come out here. Yeah, I know. There was all, no matter what you do, there's fraud in everything. On them. Yeah. Yeah. I'm telling you, people arguing against the vaccine and dying. They're willing to sacrifice their lives. That's up to them. Can they give them a what? Oh, the hydroxychloroquine lie that he went around. Oh, hydroxychloroquine should protect. Oh man, even though all the studies showed hydroxychloroquine was actually more bad than good. Man, even now talking about it pisses me off. All right, so let's stop. I got to move on. All right, let me give you, before we take out, let me do memory so we can take our morning break here. Now, memory is called the anamnestic response. It develops beginning at 12 months and fully developed by 15 months. So on a test, I always pick 15 months because that's what they want. It starts at 12, but it's fully intact by 15. Okay? Involves only IgG in the blood, Ida. Only IgG in the blood. And it involves IgE, but for allergens. Remember, IgE does not bind antigens, he binds allergens. And then IgA needs memory for the mucosal surfaces. That's how to remember the three with memory, folks. Just so you know, it's not everybody who has memory, just these three. Okay. But again, I always try to make sense of what I'm learning. So I can say, oh, I see. Now I got it. Okay. IgG for antigens, IgE for allergens, IgE in the mucosa. There it is. Easy to remember. Okay. Well, IgG is the chosen one, Justin, because he has the highest affinity. Well, that makes sense. If you're the one that can grab that antigen strongest and then destroy it, hey, we want you. So IgG has the highest affinity of all the antibodies, and that's why he's the chosen one for memory. Okay, he has one FAB, one FC. Now I'll go to structure later on. The memory, look at this, Melissa, arrives in 3 days. Why? Because IgM is not going to show up now. This is memory response. But it peaks in 5 years. Look at that. Peaks in 5 years. That's how you get incredible protection. So that's why the antibody response goes up over 5 years, peaks, and then comes down over another 5 years. That means after 10 years, you need a booster. How often are you supposed to get a tetanus shot, Karis? Every 10 years. That's where the 10 years came from. See? And that's why if you get exposed to dirt, you get a dirty wound, and you have not had a tetanus shot in the last 5 years, then we know you're on your way down. You ready to follow that? That's why I say boost it back up, because he just became susceptible again. That's why they say that. Versus I just memorized it because the book told me to do that. Because then after a while, I forgot what the book even told me to do. Okay? That's what happens when doctors don't understand. Because when the patient's right in front of them, they forget what to do. What they do, they just wing it. They just do something different. But that person is left very susceptible, and all of a sudden they die. Around the 3 days, peaks at 5 years, but it peaks at 5 times the initial response. 5 years, 5 times initial response. That's why I've had chickenpox as a child. I can walk into a room. I've taken care of hundreds of children with chickenpox. The minute I walk in that room, you don't understand, varicella attacked me. But because I had tons of IgG cleans it up, so it never even got to the first cell, and that's why you get no symptoms whatsoever. So if ever you're asked, how does a vaccine actually help you? The answer you're looking for is that antibodies will stop the virus or whoever it is from penetrating even the very first cell. If any invader invades even one cell, your body has to mount a full response. Now it's too late because you're going to go through the whole thing, whether you want to or not. Okay? So this is all vaccines just being covered right now. If they ask you, what is the benefit of a vaccine? Is to have IgG at a level so that it cleans up all of the pathogen before it can even get to the first cell. And therefore my body, zero response. Okay? Peaks at 5 years of 5 times initial response and lasts for up to 10 years. Now, if we go through this, again, this is on that page I was just talking about. So DPT, 2 months, 4 months, 6 months, and then not again till 18 months. Now you have memory, right? So memory says, well, it peaks at 5 years. I said, well, since you're susceptible out to 10 years, we got to give you another booster right here at kindergarten. I don't want you to be on your way down while you're still in a susceptible population. That's the thinking. Always have them on the way up. That way I got tons of protection. Okay? That's why they say give them one right there. And then after that, no more. See that? Why? Because it's beyond 10 years. They're out of the susceptible population now. They don't need any more vaccines. There it is, that whole series. Okay? Now look at MMR. Susceptibility starts around 18 months. That's why we say, okay, when they come in for their 15-month checkup, so let's say 15 months right here, we'll give them the first shot. That way, ahead of susceptibility. Okay? We give the first MMR in 15 months. Now, when is that IgG going to peak, Meha? For memory. Memory IgG. Now look at the slide. Don't guess. $5 years. And at 5 years, look at that. They're in kindergarten. That's why we give them one more right here. And then measles, mumps, rubella has a second peak. Second peak is when they start going to college and start living in dorms where it's overcrowded again. And then all it takes one person to spread it through the whole dorm. And that's why they say right before they go to college, boom, one more. See that? By understanding susceptibility, when are you susceptible? They're not going to understand exactly where the vaccine should be. Understanding is a whole lot better than trying to memorize all this stuff as a detail. Every vaccine, you got to memorize details, 5, 6 shots, 3 shots, 2 shots, 1 shot, 3 shots. And after a while, you got them all mixed up now. And that's exactly what happens to most pediatricians. That's why they carry the Harriet Lane or a CDC book and just copy off of that. My fear is always, if there's ever a misprint in those books, we're screwed. If most pediatricians have no idea where vaccine record comes from, then they will never figure out a misprint because you don't know what normal is. Okay? Because I remember asking my chairman of pediatrics years ago and saying, how do you keep track of what shots you got to give these kids? He said, just carry a Harriet Lane with you. This is somebody who's been practiced 30, 40 years, still have never understood it. Okay? All right, varicella. Varicella susceptibility starts about 1 year. That's why anywhere between 12 and 15 months, we give them one. And then 5 years, see that? Memory, it peaks. Okay, let's give them another one. Because you're susceptible between age of 1 and 10 years of age. Notice after that, you don't need another one. I've kept you protected for all 10 years now. Now, Rachel asked me about hepatitis B. Let me explain hepatitis B. So, Rachel, here's the answer to your question. What we found was a lot of children were dying of liver failure in their teens. We're like, wait a minute, what's going on? Where did they pick up liver disease? Nobody even knew they had liver disease. All of a sudden, cirrhosis. As it were, we only had livers for like 17% of people before that. They said, oh my God, these children are going to die then because we don't have enough livers for them. So somebody started tracing it backwards. Again, detective work. And said, that means they got to catch it early in life if you're dying in your teens 10 years later from it. And they found out they were actually getting it from their mom, who's an IV drug abuser. Prostitution, IV drug abuse, you pick up the hepatitis B, and then you pass it on to your child because you didn't even know you had it. Well, mom also passes on her IgG against hepatitis B. Everybody follow? Remember, she gives a copy of everything she has ever faced every time she has a child. Everybody follow? So now you have a child who just picked up hepatitis B virus from mom, but she also picked up the antibody from mom that'll clean up some of that hepatitis B. That's why the child never had any symptoms for the pediatrician to ever find out. But hepatitis B actually made it to the liver. And so you got low-level hepatitis over a decade, 10, 11, 12 years later, cirrhosis. And now they're dead. So that's when they realized, okay, we got to stop this early. That means the baby's picking it up in those first 2 to 4 months. They said, okay, we're going to give the baby the first vaccine right there in the delivery room. Then the question came up, how are you going to know which baby to give it to? Well, the children born to prostitutes and IV drug abusers. Well, how are you going to know who it is? You're going to ask mom if she's a prostitute? Good question, right? Who's going to ask her? You can't ask her that question. So here's what we do. We check for surface antigen. It's a surface antigen that causes hepatitis. See that? That way it's just another screening test. Nobody's being accused of being a prostitute. We check for surface antigen for every pregnancy now. That way it's a uniform rule for everybody. Check for surface antigen. If it's positive, that's the baby who's at risk. And yet we didn't have to know how mom got it. We don't need to know. Okay, we just want to know which babies are at risk. So that's why they said, okay, that baby should get the first vaccine right here. As soon as they get delivered, give it to them right now. And then give them immunoglobulin. Why are you doing that? Because mom's IgG by itself is not going to clear up all the surface antigen. So I'm going to give the baby a big dose of IgG so I can clean it all up and none of them gets to that liver. And all of a sudden, no more liver disease. It worked. So if mom is surface antigen positive, this is what we do at delivery. And then you give that child their second shot at 2-month visit, because that's the next time you see them. And then you give the next one 1 year later when they have memory. See? Now that vaccine will stick around for life. Every other child, because again, you want to make it uniform so that no parent is attacking you for only giving her babies while you guys point me out. Okay, so for every other child, we give 2 shots at 2-month, 4-month checkup. That way, every child's getting hepatitis B vaccine. But the ones who are the most susceptible, they get it right there in the delivery room. That's the protocol. Okay, but just so you understand why we're giving them two things, the IgG and the vaccine. All right, any questions on any of the vaccines, folks? On them? Good question. Primary IgG, is that structurally different from memory IgG? Structurally, no. Genetically, yes. Yeah, so your body knows these IgGs, I want them to last 10 years. These IgGs, I only want them to last 1 year. Yeah, but the structures still look like another IgG. You can't even tell the difference. Okay. All right. Let's stop there. Now go through the structure after the break. Start back at 10:40.